Hi, good afternoon, everyone. Thank you very much for joining us for this day 2. Amazing turnout. As all of you are seeing, it's over 250 people joining us on this call. And today we have a presentation from Dr. Ed Miller from the Yale University School of Medicine and the Yale New Haven Hospital. Dr. Miller is an associate professor of medicine, radiology, biomedical engineering, and he is biomedical imaging. He's also the director of nuclear cardiology there, as well as the director of the cardiology program at Yale New Haven Hospital. Thank you very much, Ed, for walking us through day 2 of this elective. And I just want to remind everyone, please chat your questions in the chat box. And also wanted to ask you for your feedback about how this program went yesterday. If you have anything that you liked, please say that. If there's anything that we can improve upon, let us know. And we are hoping that this will be an enduring activity for ASNC FITs in the future. So definitely open for suggestions on how we could use this platform for ASNC to reach out to FITs. So thank you again. And Ed, the floor is yours now.
All right, thank you, Sharmila. Sharmila, can you give me a thumbs up? You can hear me okay?
Yeah? I can hear you, absolutely.
Great, okay, welcome everybody. So I want to thank Sharmila for organizing this and also put in a plug for ASNC as a membership, as an organization for you all to start your careers with. I got involved when I was a fellow and it's really been formative through my career, and ASNC offers free membership to all fellows. So please join on the website and get the Journal of Nuclear Cardiology, as well as information about things like this. So I hope everybody can see my screen and the slides that are there. So I'm going to give a 30-minute or so talk about cardiac sarcoidosis. It's one of my areas of interest. And then we'll go through some cases in an interactive way. I have some poll everywhere type things as well, so people can interact with each other and understand how other people are reading. Let's see here. As a reminder, you should be muted as default. I see some people are unmuting themselves. Please keep yourself muted. It really decreases background noise and for everybody who is listening in. As Sharmila mentioned, you can post questions to the chat functionality or raise your hand. There's a raise your hand function on the bottom of the screen. The presentation will be recorded, and we've anonymized all the images that you'll be seeing, which does limit us to some degree for our sarcoidosis cases, but we'll do the best we can and show you some cases from our laboratory as a membership, as we talked about. So we're going to talk about cardiac sarcoidosis, although the cases we're going to review are a mixture of sarcoidosis and general nuclear cardiology studies from our laboratory. Here, I'm just, I have some of these disclosures. Excuse me, I'm going to change this for 1 second to go to presenter view. Hope that it can still is viewable for everybody. So we're going to start with discussions about FDG and myocardial perfusion imaging patterns for cardiac sarcoidosis. So when we do inflammatory imaging, we not only give the radiotracer fluorodeoxyglucose, which is a tracer that measures the cellular metabolism of glucose. We also do a concomitant study with radionuclide myocardial perfusion imaging. This allows us to differentiate the inflammatory signal that we're getting with the FDG from the perfusion imaging, which in the case of sarcoidosis and in other disease states represents myocardial scar. One of the things we've been really focused on in the Yale lab is understanding how to use the visual and quantitative interpretations of FDG PET for cardiac sarcoidosis. And we need to understand, and we'll show some examples of this, that FDG imaging for cardiac sarcoidosis requires a fundamentally different approach to its interpretation than does myocardial perfusion imaging. So I think you could, hopefully you can see my cursor here. But FDG is a hotspot technique, which means that there are areas where you have focal areas of increase. And so you should want to know what the absolute increase of that signal would be as compared to myocardial perfusion imaging, where you're looking for a cold spot or a defect or the absence of counts. So all myocardial perfusion imaging studies that you interpret on a daily basis are scaled relative to the hottest pixel intensity in that particular image set, meaning that the image intensity that you're viewing between a study that may have been done with 1/3 or half the amount of counts as a radio tracer as the comparative study is going to look visually similar in your interpretive system, as opposed to FDG PET, where you really want to be able to see the absolute intensity of the tracer relative to itself, relative to the percent injected dose. And over the course of the past several years, we've advocated that in a semi-quantitative, although more quantitative than a visual, SUV thresholded quantitative interpretation should be employed for the interpretation of FDG imaging for inflammation. And the reason we do this is because it provides additive information. We scale everything relative to the blood pool. So this small circle here, this region of interest, number 1, is the left ventricular blood pool. And what we've been able to do is measure the standardized uptake values in the blood pool on a hybrid fusion imaging system, and then use those values to create a volume of the abnormal FDG uptake in the heart, as depicted by these ISO contours, which you see surround these areas of abnormal FDG signal. In addition, we can get other metrics, such as the peak intensity of the cardiac FDG uptake, called cardiac SUV max. Now, I should take a step back and describe what standardized uptake values are. They're really a measure of the counts per pixel corrected for the time of radioactive decay, as well as the patient's body weight in most cases. So it provides a semi-quantitative measure of the counts per pixel in relative to the patient's BMI, scaled to that for the image. Let's compare and contrast this to the normal way that we depict myocardial perfusion imaging. And here's a study from our laboratory showing an FDG PET image with a concomitant myocardial perfusion study. So in study A here in the short axis images, we have a myocardial perfusion study, which from the apex to the mid ventricle you see. And as you can see, there's perfusion defects in the mid to basal inferoseptum, as well as a slight decrease in the mid ventricular lateral wall. Compare this to the FDG image shown here in the images below, where you're able to see focal areas of FDG uptake that correspond to those areas of perfusion defect. In particular, you notice that the match pattern in the inferior septum and the areas of count loss here in the lateral wall. You can also see areas where there's focal FDG uptake in the lateral wall, which haven't formed scars yet. So this provides us with some markers of the degree of inflammatory burden as well as scar formation. However, I find that this image, this way of interpreting these images, I'm going to go back here and mute everybody. Sorry, it's just getting a little bit, hearing some things here. Please mute yourself if you're coming in to the conference. And so this interpretive methodology of using a relative display convention, as is used for most of our nuclear cardiology studies, can limit us in some degrees when we're evaluating cardiac sarcoidosis images. For example, we're not able to see the extra cardiac uptake at all in these images, which can be particularly important for cardiac sarcoidosis. In addition, we're only giving a limited area of the right ventricle here, and you can see the right ventricle here in the horizontal long axis images. Another problem is scaling. And as you can see in this image, we are is somebody's writing on the screen? Thank you. In this image, what we're showing is that if we change the intensity of the image, these are all the same images, just displayed at a different intensity. So if you normalize the image in a different way, you're going to get fundamentally different results. And this is important to understand because that the absolute intensity of the FDG image is important for our interpretation. So these are exactly the same image, just normalized to make the screen intensity look lower and look higher. And you can see that you could read this study as being entirely negative, and this study as being possibly having some uptake in the anterior wall, depending on how you were to scale the image itself. And we've done some data and shown some data that show that you can reclassify FDG PET images from positive to negative if you use a quantitative approach. And this was done by one of our former residents here, who's now at Fellowship BI, Marilyn Varghese, who looked at the net diagnostic reclassification of studies that were done quantitatively and shown that we can prevent some studies from being misinterpreted overly positive by using a semi-quantitative SUV-based approach. And that has real implication because people are getting treatment based on how we're interpreting these exams. So people are getting ICDs placed and immunosuppression started based on the results of FDG PET exams. And if we're over-interpreting them or being overly sensitive because we're using a relative display convention, then we may be doing some degree of harm to our patients. Here's a nice example of how FDG PET imaging can provide added information as well. And so this is a fused, axial fused image, and the gray image is obviously the CT scan, and the colored image is the FDG image. And what you can see here as we're coming up through the heart, you can see that there's focal areas of FDG uptake in the septum here, and in the right ventricle, and in these focal areas in the basal lateral wall extending around to the apex of the heart. And you'd miss all that information if you were just looking at the degree of understanding of the overall inflammatory burden if you were just looking sometimes at a cone down or limited left ventricular image that we would see in a normal cardiac display convention. In addition, as we go up here, you can see that there's hilar lymph nodes that are subcarinal and hilar lymph nodes that are FDG avid. And those are areas that are nice to be able to biopsy for the diagnosis of extracardiac sarcoidosis. So I really recommend, and in our laboratory, we always are going to be looking over the fused FDG PET CT imaging to provide that additive information. So we do this not only to do our SUV scaling, but to define the extracardiac disease for the evaluation of cardiac sarcoidosis. And that evaluation for extracardiac sarcoidosis is critical to defining the overall risk for a patient of having cardiac sarcoidosis. For example, chest imaging, so either chest radiographs or CT imaging can show cardiac or can show pulmonary involvement in approximately 90% of people, whether that's in the lymph nodes that are large or calcified, or infiltrates, or a myriad of findings that can be indicative of pulmonary sarcoidosis. But don't forget about things like the skin. 25% of patients have some degree of skin involvement, whether that's classic erythema nodosum or Lofgren syndrome or lupus pernio or other nodular skin disorders. 25% of patients can also have ophthalmologic involvement, whether that's in the conjunctiva or in optic neuritis. Laboratory data can also give some idea about the possibility of systemic sarcoidosis, alterations in calcium and vitamin D metabolism, changes in renal function. And we use inflammatory markers like soluble IL-2 receptor in our patients. The ACE level is not particularly useful in patients with cardiac sarcoidosis, nor is troponins or BNP. Nonetheless, they can be checked for completeness. So let's go through a couple of cases here that I think will illustrate some of the features that we talked about. So start with a 72-year-old female who had palpitations with VT on a monitor about 2 years ago. She underwent a rubidium-82 PET at that time, which showed an apical inferior scar. The CMR was limited. She was kind of claustrophobic, but there was no areas of large late gadolinium enhancement. Because of the VT, Coronary angiogram was performed, which was normal. It had no obstructive coronary disease. And she underwent radiofrequency ablation because of incessant VT, and an ICD was placed. There was no thought to be at that point the patient had idiopathic VT and a possible history of myocarditis. So 1 year prior, no more VT, no history of sarcoidosis, and her EKG at the time was paced from her ICD. So here's this area of apical inferior scar. This is the rubidium 82 image. And there's maybe a small area of lateral wall FDG uptake. Let's look at the fused, let's look first at the maximal intensity projection. And we're not seeing a huge amount of extracardiac uptake. Let's look at the uptake here. Again, we're not seeing a whole bunch of FDG uptake. What we're seeing though is that in this area of the interventricular septum, there is this area of mild FDG uptake. So that's all well and good. But she progresses to have some findings on a chest CT. A chest CT was performed as part of a lung cancer screening. And she was found to have a CT scan of her chest with a left upper lobe nodule of 2.7 centimeters that grew over the 6 months from 2.1 centimeters. So here's that exam. And this is a whole body FDG PET. And right there, sorry, let's see if I can get to it. Right here is this FDG avid lung nodule. And she was sent to our thoracic oncology group with the thought being that she has developed a primary pulmonary malignancy. So she's scheduled for a left lung nodule resection. And surprisingly, when the pathology came back, it wasn't cancer, but it was a non-caseating granuloma consistent with sarcoidosis. And so now when we take a step back, we have a woman who presented with VT, who had a perfusion defect, who then had gone on for further imaging and found to have an FDG avid lung nodule that was ultimately found to be non-caseating granulomas. And data have shown that this strategy of looking at the extracardiac findings from FDG PET imaging can be useful. So this study out of Finland looked at FDG findings from PET scans to define areas that are amenable to biopsy, whether it's in the mediastinal lymph nodes or the endomyocardium. And you can see in this example image here, there are lots of areas that are particularly amenable to endobronchial ultrasound guided biopsy for the evaluation for non-caseating granulomatous infection. Another use of FDG PET imaging for cardiac sarcoidosis is defining treatment response. So let's take this case. It's a 65-year-old male who had presented with new systolic heart failure, an ejection fraction of 35%. He had a right bundle branch block 10 years prior, but that was worked up with a stress echocardiogram, which was normal, and it showed normal chronotropic response. Interestingly, his right bundle branch block preceded his diagnosis of pulmonary sarcoidosis, which was defined 7 years prior, found to be incidental in the setting of thoracic imaging, and he was asymptomatic at that time and never treated. However, in the setting of new heart failure and the new, he was found to have a new transient complete heart block, and a permanent pacemaker was placed. So here's his FDG PET image. Let's see here, I'm gonna mute that person. His FDG PET image, we have the rubidium 82 image on the top, which shows maybe some scarring in their perfusion defect in the basal anteroseptum. And he has this lateral wall only FDG pattern that it is possibly consistent with cardiac sarcoidosis, but it also can be non-specific. What's interesting here is the degree of extracardiac involvement. As you can see in this maximal intensity projection, you see these hilar and mediastinal lymph nodes that we'll see better on the axial fused image. There are all these hilar and mediastinal lymph nodes. So in this setting, he was, because of the new fall in EF, the diagnosis of cardiac sarcoidosis was made, and he was put on steroids and methotrexate, and approximately 4 months later had a repeat PET image. You see here that the FDG uptake in the lateral wall has resolved here on these short axis slices. The maximal intensity projection here shows resolution of the cardiac uptake, persistent mediastinal and hilar uptake, and I'll show you that here in the axial fused image. What we're seeing here is the hilar lymph nodes remain FDG avid, but the heart, the intensity of the uptake has severely decreased, markedly decreased, and his ejection fraction responded nicely to the change in ejection, with the change in ejection fraction. And the Brigham group has reported on this, that there is association between a reduction in FDG uptake and an increase in systolic function. And then retrospective data from their center, they showed that those patients that had a fall in their FDG uptake had a had a functional improvement in their left ventricular systolic function measured by echocardiography. And we've shown similar data from our center as well. So we've talked about the diagnosis, the use of FDG PET for extracardiac uptake. We've talked about the evaluation treatment response. One other really important use of FDG PET imaging is the evaluation of new AV block. I'll point out to you a case report that we published in JNC. This is a 45-year-old healthy white female who presented with dyspnea and chest pain. Her ECG, when she presented to the emergency department, showed a complete heart block with a narrow complex escape rhythm at a rate of 37. What was nice about her presentation is because she had a stable narrow complex escape rhythm, we were able to do a whole host of imaging before we implanted a pacemaker or ICD. So it allowed us to do the imaging sets that we're going to describe here and show in the next couple of slides. So our basic labs, Lyme serology, because she's here in Connecticut, near Lyme, Connecticut, were all negative, and her echocardiogram showed normal systolic function. So here's her FDG image, and I think it's the most dramatic image I've ever seen, showing really focal AV nodal uptake. So here in the axial fused image, this is obviously her heart, and right here at the crux of her heart is a single focus in the cardiac planes of intense FDG uptake. Well, what's also interesting is that she has abdominal lymph nodes and mediastinal lymph nodes, and those were biopsied using the thoracic lymph nodes were biopsied using an endobronchial ultrasound-guided approach and showed non-caseating granulomatous inflammation consistent with sarcoidosis. What's also interesting about this case is the idea that sometimes we can miss abnormalities in the AV node on standard CMR imaging. So she underwent an initial CMR, which is standard in our practice to do both FDG PET and CMR imaging in most of our patients who have a suspicion of new cardiac sarcoidosis. Initial CMR imaging was called completely normal. However, after the FDG PET image, we said, well, how well did you image the AV node on the CMR? And they said, well, actually, our standard imaging sequence doesn't do a very good job of interrogating the AV node. So they went back into dedicated T2 sequences through the AV node with a three-dimensional whole heart set of images and showed focal late gadolinium enhancement in the area of the AV node shown here. And this idea that there are specific patterns of imaging between CMR and FDG PET has been noted in a couple of studies. Ones that have looked at patients who presented with complete heart block versus ones that presented with VT, and those patients that presented with complete heart block, not surprisingly, had more FDG and to some degree LGE abnormalities in the atrioventricular septum. So when you're evaluating somebody with complete heart block and they're coming with sarcoidosis, your FDG PET image should guide you towards the interventricular septum, basal interventricular septum, whether it's late in the diagnosis and you're dealing with scar, or hopefully early in the diagnosis and you're able to see focal areas of FDG in the interventricular septum. Lastly, we can talk about determining the cardiac and pulmonary or total body sarcoidosis disease burden. This is a 42-year-old male with unexplained dyspnea, long-standing pulmonary sarcoidosis, palpitations, and worsening exertional dyspnea. It's a very common scenario in the sarcoidosis clinic, meaning that somebody who's had long-standing pulmonary sarcoidosis can get dyspneic. They can also have cardiac abnormalities, and figuring out which one is causing the symptomatology can be difficult to do for the clinician. So here's the FDG PET scan, and on top is the FDG images, and the bottom are the rubidium images. You see that the resting rubidium image is quite normal. The top FDG images are difficult to interpret, but doesn't appear to have a large amount of cardiac uptake. What we notice, though, on the pulmonary findings is before steroids, the predominance of FDG abnormalities in the lungs and thorax. And look at this. Look at the multifocal areas of marked FDG abnormalities in the thorax, as opposed to after steroids, the pulmonary findings melt away. Now, I will point out that there is still septal FDG abnormalities on both of these exams, but symptomatically, the patient improved dramatically after steroids, consistent with the reduction in FDG uptake in the thorax. So in summary, let's see how we're doing on time. We're doing very well. FDG PET can be useful in a number of clinical scenarios. The first is to establish the diagnosis through the specific cardiac FDG patterns. I point out to you excellent work that the Brigham Group's done with senior author Ron Blankstein, looking at specific cardiac FDG patterns and their relationship to the diagnosis. We can provide information on extracardiac sarcoidosis and sites amenable to biopsy. We can define treatment response, particularly useful using quantitative interpretation, the semi-quantitative interpretation through standardized uptake values. We can evaluate the etiology of new AV block, and we can define the total thoracic sarcoidosis disease burden activity. At this point, I think we have a couple more slides on guidelines from, these are guidelines that we wrote between the SNMI, ASNC, and the EANM, and these talk about our FDG PET guided approach to the treatment of patients with cardiac sarcoidosis, meaning that before we're going to start somebody on immunosuppression, we really want to see, for cardiac disease, we really want to see a positive PET scan, and we'll use the FDG PET scan to validate the treatment response, using a retest strategy while they're on FDG abnormalities. So at that point, this is our lab back before social distancing was in place. We're all here crowded together, but thankful to everybody in the lab for their help with the sarcoidosis studies that we've done. Okay. Now I'm getting some texts here from my fellows who are monitoring the chat room, and they have some requests from the audience on dietary, on diet and preparation. In the interest of time, I didn't go through this, but in summary, what we tell all of our patients, we use a prolonged fasting preparation for all of our patients, preceded by a day-long high-fat diet. So what we tell all our patients is the day before the test, start a high-fat, low-carbohydrate diet. We provide specific and written instructions to them, either by email or text. And we say, eat the high-fat, low-carbohydrate meal for breakfast, lunch, and dinner, then absolutely nothing to eat but clear water until the test is performed the next day. We usually schedule our sarcoidosis patients for the morning. So in general, they're getting their FDG dose around 9 or 10 a.m. So if they stop eating at 6 p.m., then obviously they have a 15-hour fast, which we've shown in our laboratory to reliably suppress markers of metabolism. So we have low fasting insulin, low glucose, and high free fatty acids in those patients. We had some things to watch out for are patients on insulin or insulin secretagogues. For patients who are on long-acting insulin, we tell them that we have them stop the insulin the night before the last dose is the night before the high-fat diet. So for example, if the study was going to be on Monday morning, we would say the last dose of long-acting insulin would be Saturday night, and they can take short-acting insulin if they need to cover their sugars for the meals on Sunday, but no short-acting or long-acting insulin after 6 p.m. on the night before the test. Obviously, that can cause some issues in patients who are very brittle in their diabetic management. What we've also found is that most of our patients who are eating the high-fat, low-carbohydrate diet, their sugars for those 24-hour period are relatively well controlled and will tolerate some degree of mild hyperglycemia as a consequence of the diet. Hope that answers people's questions about that. John, if you want to keep texting me with people's questions, that'd be great. So we're going to do some poll everywhere type stuff here. And what this is it allows us to do some real-time interactive polling from people listening to this. So to sign up for this, you text this here, Edward Miller 693 to the number 22333. So text Edward Miller 693 to 22333, and that'll sign you up. There's nothing that happens from this. It's just an app. And then we'll use this for our interactive case response and for some questions that I have here coming up. Okay, give everybody a second on that. Wow, 300 participants. I guess we limited it to 300. Looking through the names here, I see some names that I recognize. Nice to see everybody. You're here. Okay, so let's go back here. Okay, hopefully this will work. So the first one is question 1. Which of the following is the best patient preparation prior to a cardiac FDG PET for cardiac sarcoidosis? Answer A, prolonged fasting greater than 12 hours. Answer B, short fast 4 to 6 hours. Answer C, oral glucose loading. Answer D, oral glucose and IV insulin. Give this for a second. Okay, well, since I just gave that answer, I guess we're showing the correct answer is A, prolonged fasting greater than 12 hours. So the short fasting can be employed. It's more commonly employed for oncologic PET studies. So it's difficult to interpret. Oncologic PET studies for cardiac uptake, given the fasting duration is too short to change the metabolic milieu of the heart. There are centers that do shorter fasting periods than 12 hours in combination with either heparin or high-fat meals. It just hasn't been our practice. That is part of the guidelines, though. It depends on your patient population and what you've been able to validate in your laboratory. Certainly, a shorter fasting period with a more prolonged period of fasting can be utilized. Oral glucose loading is part of a viability protocol, as is oral glucose plus IV insulin. So oral glucose loading should never be employed for the determination of cardiac sarcoidosis. Other questions here, I'm getting a comment on specific FDG patterns. So if I could take a step back here, I'm gonna go back out of this and I'll go back to these imaging patterns. We really want to see the most specific imaging patterns are ones where there are multiple non-contiguous discrete foci of cardiac FDG uptake. This is a very nice example here. What you see is that there's an area in the septum in a lateral wall that's discontiguous from this area in the basolateral wall, the mid and basolateral wall. And you also have the right ventricle that's involved as well. In addition, in this particular example, you have a concomitant perfusion defect. So focal perfusion defect, which can be, it doesn't have to be in a non-coronary territory, but these focal areas of FDG uptake that are non-contiguous and really punctate and discrete are the most specific findings. Now I'll show you this other example, right? When we're looking at this example, I pointed out that this particular patient had lateral wall only FDG abnormalities, and that in isolation is much less specific for cardiac involvement. A couple of other questions here. How long after steroids do you repeat the FDG scan? So our approach is to put people on between 30 and 40 milligrams of prednisone a day, plus, depending on their clinical scenario, start a secondary steroid-sparing immunosuppressant like methotrexate at the time of steroid initiation, and repeat the FDG imaging and clinically evaluate the patient with as well at 3 months. At that time, we generally start weaning the steroids off and looking for another steroid-sparing agent if we need to, if there's still persistent significant cardiac inflammation. In our data and data from others, the steroid-based treatment at 3 months, you have about a 90% likelihood of significant reduction and about a 70% complete elimination of FDG uptake on that regimen. Another question was about the role of heparin. Heparin can be used it's the role of heparin in the setting of preparation. So the injection of heparin, in addition to its anticoagulant properties, is also an activator of heparin-sensitive lipoprotein lipase, which increases free fatty acid levels. There are some small studies that suggest that that the use of heparin can increase free fatty acid levels, and that may be helpful to improve the metabolic milieu of the heart, shifting its metabolism to fatty acids and decreasing endogenous glucose uptake. It's really center specific. We don't use heparin at our institution. I think that most places in the United States do not, just because of the risk-benefit ratio, and we found that our particular protocol has worked very well for us. So it can be used. It's not the most it's certainly not the most common protocol that's been employed around the world. How to differentiate sarcoid mismatch from hibernation? Well, they're fundamentally different protocols. The fasting protocol shouldn't because when you're doing with the fasting protocol or the metabolic protocol for sarcoidosis is limiting endogenous glucose uptake. And so any areas of FDG uptake in the heart should be from inflammatory cells, not from hibernating myocardium that's preferentially using glucose. That's differentiated from the hibernation or viability protocols where you're using glucose and insulin loading in order to augment endogenous glucose utilization. Ever see other isolated cardiac sarcoidosis? Certainly we see it, we don't like to see it, and you really have to have a very specific FDG imaging findings if you're going to make that diagnosis. We like to see extracardiac disease or define extracardiac disease through an intensive evaluation. Other inflammatory tracers for sarcoidosis, I'm going to leave that one alone for now. It's kind of beyond the scope of what we're going to talk about here today, but there are some other tracers that are in the works. Okay, here's another full everywhere question. Let me go back. Okay. Question 2, which patient has the highest pretest probability of cardiac sarcoidosis? Normal EF, normal EKG, depressed LVEF, no history of pulmonary sarcoidosis, new complete heart block in African-American man, and history of pulmonary sarcoidosis, normal echo and ECG, and no cardiac symptoms. All right. All right, well, I think the point of this question was the new complete heart block in somebody under the age of 65 has to be thought of, particularly in an African-American who has a higher likelihood of having sarcoidosis based on demographics, that you have to really think that that patient has a high likelihood of having cardiac sarcoidosis. In a patient with pulmonary sarcoidosis, we use things like echo, ECG, and cardiac symptoms to screen them for cardiac involvement. In the absence of findings on echo, ECG, or symptoms, the likelihood of having cardiac involvement is quite low. Obviously, we get a lot of patients who get referred to us for issue B, the depressed LVEF, no history of pulmonary sarcoidosis, some VT, is it cardiac sarcoidosis? And you have to read those studies with a high degree of specificity because there can certainly be a lot of lack of specificity in FDG PET imaging for cardiac disease. The answers to that question. Okay, before we go on, now we're going to go on to case review. Before we go on to case review, we want to we have to introduce you to what goes on in the Yale lab so you can understand some of these questions because we have some unique cameras. And so I'm just going to go through them a little bit here. So the equipment that I'm going to talk about today include two CZT spec systems, and CZT detectors are the solid state non-photomultiplier based detectors using semiconductors that directly convert gamma photon energy into electrical signals, and they provide high sensitivity and spatial resolution. These are called the Alcyon systems. We have two of them. We have a 570 system, which is a spec CT system. So in addition to having the CZT detectors, it has a 64 slice CT that's used for attenuation correction. So it's a really unique camera. There's like 5 of them in clinical practice in the world. The 530 system is something that you'll see much more in clinical practice. And this is an Alcyon system, again, using CZT detector crystals that provides the same spec resolution as the 570, but doesn't have the CT for attenuation correction. We also have another spec CT system, which is a wide field of view anger camera, like you're used to using. It's called a GE Infinia, but it has on the back of it one of the early attenuation correction systems called the Hawkeye system. This is a very low energy, 2-slice, slow rotation CT. So it takes about 1 minute for the CT to rotate around the patient. So it provides a very blurry CT, but one that's accurate to create an attenuation map. In addition, we have a PET system, which a GE 690 system, where we do perform rubidium-82 imaging and FDG imaging. And at one of our campuses across town, we have a GE 850 spec CT system, which is another wide field of view spec system using a CT for attenuation correction. In this case, it has a faster rotation CT, but it has a very low energy. So it's a 30 MA maximum CT using 8-slice CT system. This is a misprint. We don't have the Siemens IQ spec system anymore. So here's what these Alcyon systems look like. So this is the 570, and thank Dr. Sanusis for lending me this slide. So this is the spec detector is something you've probably never seen before. So inside of this detector, this C-shaped device, are 19 individual detectors with pinhole collimators that are focused on the heart. And so these are stationary detectors that are cardiac focused to give you a reconstruction that's specifically geared towards, or an acquisition that's specifically geared towards evaluating the heart. This gives a very high sensitivity, much better than traditional detectors, greater spatial resolution, high energy resolution. Because these detectors are stationary, we can also perform dynamic imaging, meaning we can acquire all the counts over time, analogous to what you do with PET, to allow us to do dynamic imaging for SPEC, to do things like myocardial blood flow quantification. And this allows us to markedly reduce the dose. So for our detector systems using the Alcyon, we use about our low dose image is about 8 millicuries of tetraphosmin, as opposed to, you know, the standard 12 and 30 millicuries for low dose, high dose. So we're starting off with patients and using a stress first imaging strategy. We can do a study with 8 millicuries or less of tetraphosmin using the LCN system. Here is now one of our junior attendings, Dr. Brian Young, in the LCN system, showing you what it looks like for the patient. So they go in head first, hands over their head. This is the CZT detector system on the gantry, and behind it is a 64 slice CT system. This is the more commonly utilized in the community 530 system. So again, the CZT detectors on a small gantry. So this is something that can be used in an office-based practice. Again, the hands go over the head. One of the downsides of this camera is it has near uniformly gives pretty significant diaphragmatic attenuation. And so if you don't have the CT, you're likely going to have to prone the patient. So all of our patients who are getting 530 imaging without attenuation correction, we would ask the technologist to see if that patient can be prone and do a second set of prone images. As you can see here, this is how that's performed on the 530. Hawkeye system this is a traditional wide field of view camera. So these are the two Inger detectors. Now you notice something that's also sort of an interesting anachronism of the Yale lab is that we perform all of our imaging with our detectors 180 degrees apart for a 360 degree acquisition, as opposed to an L mode acquisition where the detectors are 90 degrees apart. And this is a long-standing tradition in our lab. We think it provides better cavity resolution. I will point out that the ASNC guidelines recommend the L mode acquisition. Nonetheless, we perform the H mode acquisition of the detectors opposed to each other. On the back side of here is the slow rotation CT scanner for the CT attenuation correction. I see a question: why isn't prone positioning the default for the 530? It certainly is reasonable to do so, but about 40 or 50% of patients can't prone at all due to being obese. Usually is the issue. So if you go back here, laying, if you have a big belly, it doesn't feel really comfortable to be laying down for 7 or 8 minutes. Okay. Okay. So now I'm going to switch over and I'm going to start doing some cases. And let's see, I'll get there in just a second. Okay, and new share, Citrix, share. Okay, you guys should be seeing the Envia screen, right? John, everybody seeing that? I'm going to take that as a yes.
Yes, Ed, I
Okay.
just unmuted myself. Yes, we can see the images. Beautiful. Okay,
great. Thanks, Charmel. Now, I know you talked about yesterday with Dr. Dorbala about how to interpret nuclear cardiac nuclear imaging. I want to go through and really reemphasize, when we get new fellows into our lab, we spend a good week or so really orienting them to use and understand how to use the imaging workflow that you're going to be reading from. In our case, we use Envia or 4DM, which is one of 3 or 4 major nuclear cardiology display systems. And I bet that they have 60 or 70% of the market share for interpretation of nuclear cardiac imaging. And when you get Envia or you get any program, realize that it's fully customizable to make it look and do whatever it is you want it to do. And you have to spend time early on in your career spending time with the buttonology so you understand what you're seeing and what you're looking at. Because it's kind of like it's kind of like an Android phone. You can make it do anything you want it to do. You can make it display any sort of studies in any way that you really want it to do so. And if you don't know how it's set up, if you haven't taken that time, then you're gonna do fine 80% of the time, but in the 20% of the time where the cases are challenging, you're not gonna know how to troubleshoot them. So I'm gonna take you through what we've done here in NVIA to customize this, and this is standard practice and is the standard display convention across all of our 10 or so nuclear cardiology labs in the Yale New Haven health system. So if you look over here on the left-hand side, there are these little mini tabs that describe the workflows. And our workflow starts at the top. Now you notice in this tomographic QA here that I'm clicking on, I hope you can see that I'm clicking on it, nothing's coming up. You would normally start your evaluation of a nuclear cardiology study looking at the raw rotating images. However, you also see that what we're showing you here is that this is done on the Alcyon camera. I mentioned that the Alcyon camera uses stationary detectors, so there is no rotating tomographic image that you're used to using for quality assurance. So we have to go to a different place for our quality assurance, and I'll show you that at the end. MI processing in NVIA is where the limits are set for either the bullseye plots or the ejection fraction for the gated imaging to determine the end-diastolic and end-systolic volumes in this case. Assuming that your technologists or yourself have set these edges correctly, and we've defined for ourselves where the gated images should start, and we're happy with the bullseye plot limits, we can go on to our images. And in this case, we set up on the 570 system a review of the non-corrected, non-attenuation corrected image, a review of then the attenuation corrected image, a review of the non-corrected and attenuation corrected images together. So in this case, what we're seeing is the non-corrected images, the raw images without attenuation correction. And in this particular screen, just because of sort of a quirk in what NVIA will let us do, we're seeing two sets of images that are identical. So even though this is the gated stress image, and we could play it, have it gate, its default is the summed image, analogous to what you're used to seeing for the demonstration of perfusion. So here we have the stress image from apex to the base all in one line, the horizontal long axis image from inferior to anterior, and the vertical long axis image from septal to lateral wall. The attenuation corrected images, when we add them in here, have made this image look even more normal than it did before, and we can show both sets of image data either in grayscale or in cool for our final interpretation. So here we have the stress non-corrected, the stress attenuation corrected, short axis, horizontal long axis, and vertical long axis. So I wanted to start with a normal case so you'd understand what an Alcyon spec CT image looks like. So we have stress and stress AC. So this is a stress only image. We don't have resting images in this patient because we reviewed this images after stress, and we found that the stress attenuation corrected stress image was entirely normal. There are no perfusion defects here. We can validate that in our perfusion summary image, right, which are our bullseye plots. We had to develop an internal normal database for the Alcyon attenuation corrected system. You can see here that the sum stress score for both the non-corrected and the attenuation corrected image is 0, meaning that according to the computer, it's all normal. We can then go through our functional summary, and I'll change this. We have end-diastolic, end-systolic, and gated images. We see that the ejection fraction here is 80%. The end-diastolic volume is normal at 54, and end-systolic volume is small at 11. So this is forming up to be a completely normal image. Again, we can provide more quantification. These are images you've already seen, our polar maps. This is just a different way of doing the quantification. I won't go into this now. We can look at more gated movies if we want to see more areas of regional functionality. With the 570 system and with any hybrid spec CT system, you're going to want to spend a lot of time reviewing the CT that's performed for attenuation correction. So this is our attenuation correction CT with default to the axial field of view. It's called the transverse image in VIA. We also have coronal and sagittal images. What we'll do is we'll start our review of the CT, and all of our CTs are read for cardiac findings by the cardiologist, as well as overread by a radiologist for non-cardiac findings. This is part of an ongoing societal discussion about how we handle hybrid spec CT images as a community. But in general, our philosophy is that these, because as you'll see, there's a lot of information in these images, we feel that it's really important for a risk management perspective and good patient care to have all of our CT images overread by a radiologist as well. So we'll start here at the apex, or the superior limits of the CT acquisition, and we're going through and we're looking at the aorta for areas of calcification, looking at aortic size, coming down to see the pulmonary artery and looking at pulmonary artery size. And then we're starting to look at the ostium and the origin of the coronary arteries. Here's going to be the left main, the LAD, circumflex coming down. And then we'll see over here the origin of the right coronary artery. And we're looking for any evidence of atherosclerotic calcifications. We don't see anything in this patient. So this is a really nice normal CT from a cardiovascular perspective. The atria look normal in size, left and right atria here. Left ventricular size, right ventricular size looks normal and small. There's no evidence of atherosclerosis, and the anatomy look normal. We'll also take a look again at the lungs, and oh my, so now we're seeing obviously major emphysematous changes in the lungs. And we're going to be looking through for any evidence of large nodules or masses. Again, these are overread by our radiology colleagues. But you see that, if this is in this particular patient, the history was a 48-year-old active smoker who has liver cirrhosis and is undergoing risk stratification for a liver transplant. Obviously, this puts her into a lower cardiovascular risk category, but it provides us with additional detail about her overall clinical course because we see that the degree of emphysematous changes in her lungs. Can you comment on imaging for myocarditis? For FDG, so the question was in the comment section, can you comment on imaging for myocarditis? We do perform limited FDG imaging for myocarditis in certain scenarios. It's not our routine, but we have performed it before for different, I think we performed it in the case of a couple of cases of suspected DRESS syndrome, for example, eosinophilic myocarditis, been some case reports differentiating myocarditis or if we're looking for tumors or cardiac device infections, we've certainly performed FDG imaging as well. Now, going back to this case, one of the other unique aspects about this, the Alcyon system, and we talked about the lack of tomographic images. Well, this is the tomographic image equivalent. And what this is, remember that the Alcyon system has 19 individual detectors. This is an image from each of those detectors that's used for the reconstruction. And because there's very limited movement in the detector array, we have to make sure that technologists get the patient into the center of the field of view. And these detector images allow us to perform quality assurance to make sure that the image is centered and the patient is in the center of the field of view. One second. I think I have a question now that I was going to add. Let's go back to my PowerPoint. So now, compared to traditional SPECT, we just talked about CZT SPECT. The administered doses of radiopharmaceuticals with CZT camera should be, yeah, exactly, lower. So much lower. Much lower than they would be with the traditional system. Our next case is an FDG case. And I thought that let me see, do I have any, let me go to my participants. Do I have any volunteers who want to read an FDG PET case for evaluation of cardiac sarcoidosis? You can raise your hand. If you do, and I'll be nice. I'll lead you through it. I'm not seeing any hands raised. I can pick on my Yale fellows, or I can pick on one of my prior PhD. Oh, wait, who do we got here? Nick. Okay, I'm going to go. Nicholas Pilas. Okay.
Yeah. Hi, Dr. Miller. Yeah.
Hi. How are you?
From Cleveland.
You're from Cleveland.
Yeah.
Okay. Well, thanks for stepping up. I'll be nice. Okay. So this is what I was talking about with NVIA. NVIA is a little funny in how it represents FDG cases, and so it starts by this workflow called the inflammatory workflow, and I'm just going to process it here for you so it lines everything up. And then we're going to start with these sets of images. So on top we have the resting rubidium 82, and the bottom we have the FDG. So
sure.
What do you got for us, Nicholas?
Yeah, sure. I see the resting images. There is a septal and anteroseptal resting perfusion defect, starting from the apex all the way almost to the base. Mm-hmm. And in the same areas on the FDG, I see FDG uptake. So this could be, let me see if I see anywhere else FDG uptake too. So yeah, so I see also FDG uptake in the inferior wall on the vertical long axis views. And yeah, so I'm debating if, because we have a resting perfusion defect with FDG uptake, I'm trying to differentiate and think, you know, if this is hibernating myocardium or active inflammation. But I see also RV uptake with FDG, yes.
Yeah, no, Nico, thank you. So be careful on these, because as you can see, when we default, this is the default magnification for our NVIA. Mm-hmm. And a couple of points I like to make sure that people realize. Some laboratories, the technologists have been taught to really cut off the RV, right? To cone down and to eliminate any RV from being visualized. I've never understood that, but I've seen it at different laboratories. And then you saw that in order to see the RV, I actually had to make the whole image smaller, right? And when I do this, it becomes really obvious, right? That how much RV uptake there is. You can see it on the perfusion image too, and it's better if I grade it up, right? Yep. So that's a good point to point out.
Yeah, great.
you see, so sort of in summary, you had a, what do you think? Can you give me your summary interpretation again?
Sure. There is a resting perfusion defect, mainly in the septum, and there is FDG uptake in the same area, as well as the RV, which could suggest active inflammation in these areas.
Yeah, that's exactly right. Here's how we read it. I'll read it for you. We said it's abnormal, and we said there are multiple abnormal foci of FDG uptake in the heart, including the entire RV free wall, right? The entire septum, and a focal area in the inferolateral wall, sort of in this area here. And these are our focal areas here. And right there, I think, is where we're talking about. Inferolateral wall. In terms, and then the large size, severe intensity perfusion defect in the entire base to apical septum. Okay. Now that this is what's, obviously that was very good. Thank you, Nico. But one of the things that, I think that INVIA and some of the other programs are starting to work on, but need to improve, is how they're quantifying the degree of inflammation. So if you go back here to the inflammatory workflow in INVIA, what they've shown you here is they've taken a contour around the FDG and given you a polar map here of standardized uptake values for the left ventricle. And you can see here that they've given you averages, and I don't know if this projects well, of 4.7 for the septum, 3.6 in the inferior wall, 3.3 and 3.6. And this gives, down here, they projected for you a mean and a max SUV, a max of 7.0. One of the issues that I have with this is that this is obviously completely LV-centric, right? It's discounting all this stuff that's going on in the RV, and that RV uptake has been shown to be a really important predictor of prognosis. In addition, we don't know where that SUV max is. Like I can guess it's kind of over in this area, but I'm not sure. And that lack of certainty of understanding, geographically where that's located, I think it can be a problem. So the Fusion viewer can help you, but we have to make sure that we have it on FDG statics, FDG static sarcoid here. And now when we look at the Fusion viewer, oh, holy cow, not only are we seeing that distribution of FDG uptake in the RV, but look at this nice juicy subcarinal lymph node right there that's right next to the esophagus and ready to be biopsied with a needle by your interventional pulmonary group, right? As well as these hilar uptake, right? And so if all you're doing is going back here and looking solely at this image data set here for your interpretation, then you're going to miss out on the intensity, the distribution, and the extra cardiac findings for the sarcoid imaging. Does that make sense? I see a question. Do you quantify severity, size, and heterogeneity in terms of SUV volumes and coefficient of variance for serial comparisons? Very nice question. So the markers that we report are the peak intensity, the cardiac SUV max. We do our metabolic tumor volume or cardiac metabolic volume measurement, which is that volumetric measure of the abnormal SUV areas of the myocardium. The coefficient of variance is the mean SUV values divided by the standard deviation of those means, and it's not something that this program does, and so it's mathematically challenging for us to do, to take all those. We would do it from, I think we'd do it from this, and we would measure the mean and then the standard deviation of those measurements. So I know that the Cleveland Clinic does a lot of work with coefficient of variance. We haven't been using it. It's certainly an interesting concept, but I also think what it tells you is kind of what's already sort of intuitive, is that the focal punctate areas, meaning large heterogeneity and SUV values, are important for the diagnosis of cardiac sarcoidosis, which is kind of already something we knew. So, what do we see here? There's a lot of stuff coming in. What SUV wall to blood pool ratio do you use to identify positivity? Yeah. So if you go back and look at our papers from 2014, we derived, based on the scanner that we had when I was in Boston, a value of 1.5 times LV blood pool SUV minimum as the threshold for SUV positivity in the myocardium. So I'll say that again. So you take a region of interest and you put it in the LV blood pool, and you find the minimum value in the LV blood pool, and you then multiply that by 1.5, and that's your lower limit of normal, or lower limit for myocardial SUV abnormalities. I can show you that here in the in this slide. Going back to the so here LV blood pool SUV, and we take that and times it by 1.5, and then use that to create these isocontour thresholds. If you go back to we looked at 1 times LV blood pool, 1.5, and 2 times LV blood pool, and 1.5 gave us the best visual concordance with what we were seeing on an SUV scale. If you look at the Michigan program here, the INVIA program, they measure their blood pool here, SUV of 2, and use that for their SUV threshold. You can change that up here, and you can do a multiplier of 1, or whatever you want, or of like 2, right? So you see what it's doing, it's changing the areas that it's calling abnormal. You can also set an absolute scale. Sorry, right here. Oh, right here. No, sorry, right there. So you can set an absolute scale, an SUV of 2.7, for example, like you know, Ron and others have published on this, or you could set something higher, like 4.1. These SUV values, you know, are really dependent on a lot of factors. So what we use at Yale and what they get at the Brigham are going to be different, probably to some degree, than what you get at other places, because it depends on the doses you're using, the incubation times you're using, I mean the duration of time between the time you inject FDG and you image the patient, as well as the type of scanner and the reconstructions you're using. So if you have like a new digital PET system at your institution, I suspect that the values are going to be much different, and you're going to have to figure those values out in order to define them and use them quantitatively. Does this patient have extra cardiac involvement? Yes, this patient does. So again, this is the fused image. We're looking at the FDG image over the CT, and you see that here's the FDG avid subchorial lymph node. We don't use this program for our hybrid imaging review. We'll use either the GEAW or our Visage systems, but we couldn't project those in an anonymized way. So we're using what we can do for HIPAA compliance for this purposes, what we do. Do we acquire only cardiac field of view or head to thigh? Yeah, you see here, we do a single bed position, cardiac uptake, and that's having to do with our scope of work for our scanners, as well as insurance reimbursement in Connecticut. I know that other institutions will do larger field of views. All right. What's next? Case 19. All right. Case 19. So who's my victim for this one? can either raise your hand or give yourself a comment. Got 274 possible people to pick on. All right, I can start looking through the list. Well, I can call on my friend Dr. John Stendhal, who I know who is home on baby duty. So if the baby's not crying, John, can you interpret this PET for us?
Currently lots of crying here, but maybe be quiet here for a little bit.
Okay, I'm gonna. Who are we gonna give this to then? I don't think that's fair. Jennifer Kwan. Jennifer Kwan is on. Jennifer, are you available? John, I'm muting you back.
Thank you.
I was muting you. There we go, muting you. Jennifer, are you available?
Can you hear me?
Yeah.
Okay.
Can you see the image?
Can't see the image.
Okay, that's going to be hard to interpret then.
Yeah, processing.
What's that? Oh, okay. Yeah, you can see you can see the screen though, right?
Yeah, I can see the screen.
Okay. So here you go. So now for the group, this is Jennifer Kwan, she's one of our second-year fellows. So this is 65.
Like
You want the history here first, Jennifer?
Sure.
Okay, 65-year-old man, history, hypertension, hyperlipidemia, COPD, CKD, who had bypass surgery in 2015 with a limit to the LAD, an SVG to the RPDA, and an SVG to OM2. He has peripheral arterial disease. He's undergoing risk stratification for vascular surgery.
Okay.
Okay, so yeah.
All right, so looks like he has at least a medium-sized defect from the basal to apical wall, lateral wall, that is reversible, kind of mild intensity. We also see it on the horizontal long axis view as well. And it's not as, on the vertical long axis, I don't think it's as obvious, but I think in the short axis and the horizontal long axis view, we see that defect, reversible defect.
Very good. I also saw that Dr. Gerber's on. Dr. Gerber, one of our nuclear cardiology attendings, do you have any points of wisdom you want to add to this case?
No crying babies, so I can't really top that one. So yes, thank you. Yes, Jennifer, that's a great interpretation. I'd like everybody to take a look at the cavity size. We look, to pick up on Ed's narrative, if you look at the frame to the left in that beige colored bar, we have a number in 4DM for TID. And this is giving us a 1.17 ratio of cavity size. You can use whatever cutoff you want for that. Most labs are going to use 1.2, 1.25. We tend to be a little bit more specific in this regard, using 1.3 internally as our kind of mental note for cavity dilatation. But there's definitely a change in LV cavity size stress to rest on these two images. So that would make you suspicious, not just of the degree of ischemia and its burden, but perhaps some additional global ischemia as well.
Thanks, Jamie. we also teach our fellows that TID is something, and cavitary size changes are something to look at in grayscale. You'll get a lot of pseudo contouring here in the cool images. So keep that in mind. You'll see that on our perfusion summary. I should mention that this is a PET image, by the way. This is a rubidium 82 PET image, and so both the sets of images where all our images are going to be attenuation corrected. So you're going to have stress and rest attenuation corrected images. Our perfusion summary shows this large, quantified large, moderate defect that Jennifer described from the base to apical lateral wall. Now here's what kind of gets interesting with this case. Now with PET, as Dr. Dorbala published some years ago, one of the important parameters is change in LVEF with stress. Because remember, with PET, you're taking your ejection fraction measurement during peak hyperemic stress, right? So the patient's underneath the camera while they're getting their regadenoson or adenosine or dipyridamole infusion. And so you're acquiring the images during that period. And so if there's any transient myocardial ischemia that's going on, and LV cavitary dilation, fall in ejection fraction, you're going to pick it up. As opposed to our SPECT images, where remember with SPECT images, our EF is taken 30, 40 minutes after the stress is ended, whether it's exercise or pharmacologic. So these numbers with PET are really important to pay attention to. Now here you have an EF that goes up by 1 percentage point, so we're not getting that transient LV dysfunction or negative EF reserve that Dr. Dorbala had described as a negative prognostic factor. But it is a little bit suspicious. You see that the end diastolic volume is increasing 87 to 106. So with all of our PET images, we do dynamic imaging for myocardial flow reserve. So for those of you that aren't familiar with PET, this is a technique that we acquire all the counts over the entire period of the acquisition and replay them relative to time. Let me show you that a different way. So up top here, we have our normal static images. But if I replay them, what you're going to see is the tracer. Here we go. I'm going to go into the RV, right here, and then going into the lungs and then filling the LV cavity. And then from the LV cavity, going into the aorta and obviously finally ending up being trapped in the myocardium. From those dynamic imaging, we can create then time activity curves. Here's the left ventricular time activity curve and the individual myocardial time activity curves. And because we know the rates of the rate of uptake in those various compartments measured by the time activity curves, and we can make some assumptions about vascular permeability and the physical properties of the tracer uptake, we can then model and mathematically derive myocardial blood flow, which is different than relative perfusion. It's giving us a quantitative value on a per segment basis for myocardial blood flow. And that's described here in these polar plots. So what we're seeing here is segmental myocardial blood flow at stress and at rest, and the ratio of those stress and rest blood flows called myocardial flow reserve, or MFR, previously called CFR. I can display it here more clearly. So if we make some arbitrary distinctions about what we want to call the LAD, the circumflexing RCA territories, we can tell you what the stress and rest blood flow is in those territories and the ratio of those two. Jennifer, you want to add to your description of the perfusion defect now that you know the flow values here?
So the global flow reserve looks normal, but the stress for the left circ territory is reduced, is abnormal.
Yeah, absolutely. So but it's also very interesting that the resting blood flow is reduced compared to the other resting territories, and the stress blood flow is markedly reduced compared to the other stress territories. There's also some suggestion here that perhaps there's an impairment in right coronary flow, even though the reserve is normal. So this potentially adds to our understanding of the overall disease burden. In this case, it appears to be epicardial because of it involves a focal vascular territory. In addition, with this particular patient, with all of our PET patients, we do a CT for attenuation correction. In this case, first thing we're seeing is sternotomy wires. We're seeing post-CABG changes and then marked LAD calcifications, aortic calcifications, left circumflex. So it looks like there's a circumflex stent here.
Mm-hmm. Ascending, descending aortic calcifications,
yeah.
RCA calcifications.
Here's the RCA coming down as well. Okay. On our lung windows, no major abnormalities on gross inspection. Any questions on that case? What cutoff? What is the cutoff of MFR to be abnormal? That's a great question. So going back to these values here, so the best data on this are large retrospective series that looked at major adverse events. And in that data, there's a gradation of increasing event rates as flow goes below 2 and below 1.5. The event rate becomes markedly higher. So high risk studies, so abnormal, we use less than 2-ish as abnormal, but realizing that the inflection point for significant increase in risk is somewhere around 1.5. Again, these variables depend a lot on to some degree on your methodology, whether you correct for hemodynamic changes that are occurring during stress or with rest and hypertension, etc. For heart, for sometimes patients with CABG may have confusion flow values. That's true. There could be a lot of concomitant microvascular disease. For heart transplant patients, do you use absolute flow? Yes, we use myocardial flow reserve to follow our patients for transplant vasculopathy. Case 19, the MFR measurements in this study, remember we had the regional flow problem in the circumflex. The study is low risk because the CFR is greater than 2. The perfusion defect is false positive. The patient has microvascular disease and epicardial disease. The patient may benefit from revascularization. And I think I ask people to choose all the possible answers, not just one possible answer. There's multiple possible answers. Go. You can't, if you text to the Zoom chat, it doesn't work. It doesn't look like this is working either. People are basically pitching C and D, and that's correct. The patient may benefit from revascularization, and there's probably a component of microvascular disease, although the most prominent feature here is epicardial coronary disease. Apologize, this isn't working. All right, let's go back to our cases. Okay. Okay, so I need a victim, a volunteer to read this SPECT CT case. either raise your hand or or identify yourself in the group chat. $246 people, and I don't get a single volunteer. I usually am pretty nice. I don't berate fellows very often.
Hey, Dr. Miller. This is Peter. I'm happy to take this one.
Oh, Peter. Okay, thank you. Where are you from, Peter?
I'm from Cleveland as well.
Okay, wonderful. So, say hi to Dr. Kramer and Dr. Sakara and others.
Oh yeah, for sure.
All right, so so this is a SPEC CT study. So this is done on the Alcyon system, okay? So we have SPEC CT, and the history is, let's see, this is case 20. 64-year-old man, history of complex CAD, that's all I have, and presenting with exertional angina. Okay, so high pretest probability. I'll show you the non-corrected images, but I think it's probably easier just for the interest of time to show you all 4 image data sets. That's okay. So here we have, this is a SPEC CT case. We have stress and rest without attenuation correction. And then we have stress and rest with attenuation correction. Obviously short axis, horizontal long axis, vertical long axis imaging.
Okay, yeah, just looking at the stress and rest first. It looks like there's a inferior perfusion abnormality starting at the apex compared to rest. And then looking at the attenuation corrected images, yeah, looking still comparing the stress to rest, I would say that defect is still present, especially towards the apex. And also, it doesn't fully correct, I would say, in the mid segment as well. I'm looking at the vertical long axis now as well. Yeah, so the basal inferior and mid wall do correct a little bit. Not sure if they correct completely with the attenuation correction.
You're talking about these areas here?
Yeah, looking at between the stress and rest. Yeah, so that looks like it corrects actually right there. And then looking at kind of 23 and down to the left. Yeah. So we're comparing the stress in the inferior wall to the rest. It doesn't look like it completely corrects.
Yeah, I agree with you. And I get the question that always comes up with, so for those that don't do CT attenuation correction a lot, if you just had these images here, right, which are the non-corrected images, you would say, well, gosh, there's this perfusion defect. We start at the apex and go to the mid ventricle. It looks pretty fixed, right? And but it could also potentially involve the basal portions of the inferior wall, and it's sometimes challenging to know whether that's diaphragmatic attenuation or a true defect. When you add attenuation correction back on, or add attenuation correction on from the CT, you see that the inferior defect in the basal portions becomes almost completely filled in, suggesting that there was diaphragmatic attenuation. Now, one caution is that we tend to, we realize that CT-based attenuation correction does tend to overcompensate in the inferior wall as compared to the, so that it may add too many counts back to the inferior wall and decrease the overall sensitivity. But I think in general, we'd feel, we'd be less inclined to call anything in the basal to mid portions of the inferior wall. But certainly we would think that this mid to apical inferior wall is, there's a perfusion defect that appears to be partially reversible. Right? Anything else, Peter?
Yeah, just looking at the cavity size, looking at stress and rest, and this is a SPECT image, so this is even more concerning to me. But it looks like there's probably some TID there with stress as well compared to rest.
Yeah, you see that here? Everybody see this? And quantitatively over here on the non-corrected images, which is what we're using for calculate TID, you get 1.25, which getting to Dr. Gerber's point is getting upwards towards our threshold. I think visually here, there appears to be some transient ischemic dilatation. What else can we look for here? How about any other perfusion defects? Well, sometimes it's helpful to go to the quantification, see if it picks up anything that you didn't see. It really doesn't. You describe that inferior defect. Somebody's saying anterolateral wall. Yep. So right up here, right? See that?
Yeah, I agree.
High basal anterolateral. And sometimes you may miss that in these quantification schemes because you see it, but because I think these quantification schemes, the polar plots are so used to having basal drop-off, they're probably less sensitive for the quantitative depiction of these lateral wall defects. But I think that this defect would be something that we would probably call. So we've got TAD, we've got partially reversible perfusion defect, we've got multiple two perfusion defects. Now, one thing that also comes up here is what the heck's going on with the RV? Okay, this is easier to see in gray.
Yeah. Yeah, so you can see that, yeah, especially with, you see it even, RV uptake even at rest, but definitely with stress there.
Yeah. You know, transient right ventricular visualization was a phenomenon that was more commonly described with thallium. But certainly it makes sense that, you know, if you have development of right ventricular dysfunction, left ventricular dysfunction, pulmonary hypertension, and you get transient increase in right ventricular pressures, you get RV visualization, or if you have relative count, your relative count differences are much lower between the right ventricle and the left ventricle here at stress than they are in rest because of global ischemia, then that could be a possible mechanism for right ventricular visualization. And here I think you see that very nicely. Perfusion summary, function summary. Now, anything here?
So looking at the gated rest images, the LV cavity looks, I don't see any discrete wall motion abnormality. And then looking at the gated stress in the short axis, and you can see that there is TID, looks like, with the gated stress. And then that the inferior wall, I think, is also a bit hypokinetic.
Yeah, maybe a little bit, right? I think right here.
Yeah.
I caution, this is another thing that, you know, we talked about in EF falling, and this is a place where I wouldn't necessarily, you know, I don't know, this is on the borderline, but remember that these changes in EF can be due to measurement error, dose and low dose imaging with SPECT. They're taken at much different times. So you have to be very conservative when you're talking about EF falls with SPECT. The other comment about TID, remember that TID is calculated. You notice that in the function summary of VIA, there is no TID measurement here. And the reason is that TID is calculated from the summed image, right? TID predates the advent of gated SPECT, right? So, it's not from the, at least in VIA, TID is not from, it's not the ratio of the gated and diastolic volumes. It's the ratio of the summed image volumes here, 111, 89, okay? What else was I going to say about this one? Let's, somebody asked, would PET be better for this patient? I don't know. This is a pretty good quality spec study. You know, we've identified a lot of high-risk features, and that was my question I was going to ask. I'll just give you those comments. There's multiple reversible perfusion defects. There's TID. There's increase in RV uptake, and there's some wall motion abnormalities, and maybe a fall in LVEF with stress. So I think we've already determined this is a patient with some high-risk features. So. It's a good quality study. I think the overall image quality is quite good. So I don't know if PET would really help us here. Let's look at the CT viewer. So, oof, right? We go up to the apex, he's a lot of calcium. I'll let you, Peter, I don't want to put you on the spot.
Sure. No worries. So no median sternotomy, no prior CABG here. So left main LAD at diag, circ, they're also really calcium. Oh, that might be a stent actually.
Yeah, it looks like a stent, doesn't it?
Yeah. Circumflex.
Looks like another stent.
Maybe a stent as well. Yeah. Aortic valve calcification, and that's maybe a stent in the RCA as well.
So it looks like 3 vessel calcifications and stenting, aortic valve calcification. Also we'd comment here, I think, on at least left atrial enlargement.
Yeah.
LV size looks fine. Let's look at the pulmonary artery size looks fine here.
Okay.
Okay, aortic dimensions look reasonable. And then we'll look at the lungs. Watching somebody else read a lung CT is like watching paint dry. So there's no like major abnormalities here. Generally, how long after rest and stress injection should we start imaging to avoid the gut uptake? Those are good questions. So you're going to want to go longer depending on your radioisotope, whether it's tetraphosphamide or sestamib. Refer you to the ASNC guidelines for the specific recommendations. Our usual post-stress, we use tetraphosphamide, so our post-pharmacologic stress uptake is imaging acquisition occurs about 30 to 45 minutes after injection. Okay, let's move on. This is this is a viability study. An FDG viability study. Thank you, Peter. Appreciate it.
Thanks, Dr. Miller.
Thank you. Who's next? Natalia. Natalia, are you available to look at a viability study?
Yes, I am, Dr. Miller. I should have volunteered.
Well, you should have volunteered, yes. Did you see the group chat about cookies? There were cookies today.
There were?
Yeah.
Oh, man.
Okay, so are you ready?
Yes.
Okay, so this is a PET viability study. We have here an FDG study. So this is glucose loaded for everybody, right? So this patient, we use oral glucose loading followed by IV insulin, IV regular insulin if needed. We wait till the FDG, or the serum glucose is less than 140, and then we inject with FDG, and we wait 60 minutes and take a static FDG image. And we also do concomitant resting rubidium-82 perfusion. So on top, we have RB82, and on bottom, we have FDG. I'll read you the history. 60-year-old man, hypertension, hyperlipidemia, COPD, anxiety, who presented with VT arrest, and then had a left heart cath with multivessel disease, and what's the only note says likely chronic
CTO-RCA.
Okay.
What was the last thing? CTO of the RCA?
CTO didn't tell me. It must be the fellow didn't provide the correct information in the history.
So I think on the rubidium images on top, we can see that there is a resting perfusion defect that involves the infralateral and inferior walls from the base almost all the way to the apex. So that's that part. Can you hear me?
Okay. Yep, got that. So we got a resting perfusion defect. And I will say for the audience, it's not uncommon for us, probably 2 or 3 times a year, to get a referral for an outpatient viability study for somebody who has had a SPECT done without attenuation correction or on a lower resolution camera, and we do the resting perfusion and it's completely normal, right? So the perfusion defect seen was artifactual at outside lab. But this one is not, this one's real. So we got a perfusion defect, yep.
And then I think with the FDG injection, most of that wall starts picking up FDG. Not sure about the base, but the mid does.
Yes, exactly. Thank you. So what she's describing here is a flow metabolism mismatch, right? So flow, abnormal perfusion, metabolism, you get some, at least preservation, but in some degree, some accentuation of FDG uptake, particularly right here, suggesting that there is some, even potentially some repetitive stunning here in the apical portions of the infralateral wall. And so this is so how would you say, what did you say what areas of the heart are viable?
Yeah, so I mean, obviously the areas that don't have a perfusion defect at baseline are all viable and should be reperfused, but the CTO of the RCA probably should also get reperfused. Yeah,
exactly. So I do like the INVIA viability screen here because it breaks it down by region, right? And it takes and says, well, what areas of the heart have normal or abnormal perfusion? If they have normal perfusion, then by definition they're viable, right? If they have abnormal perfusion, then you have to go to your FDG to figure it out. So the LAD here is saying, well, all the perfusion in the LAD territory is normal, so so there's 100% viability. In the circumflex territory, it's kind of arbitrarily defining that defect is between the circumflex and the RCA. It's saying there is a perfusion defect, so shown here, but that area fills in with FDG, and then there's no scar. And same with the RCA, more scar. Less scar and more hibernation. So if I'm writing this report, I write this as the entire left ventricular cavity is viable. The LAD shows normal perfusion, is therefore viable. The circumflex has small area of resting hypoperfusion, but accentuation of FDG, suggesting viability and hibernation, while the RCA is predominantly hibernating myocardium. Okay.
Sounds awesome.
Thank you, Natalia. All right, I think we have time for one more. Actually, let's go to, this is kind of a very interesting case. It's a thallium case. You guys are saying, thallium? What are you doing showing us thallium cases? Well, with the Alcyon system, so remember thallium has a, has really nice, has better physiologic properties than the tech-labeled radiotracers, but we don't use it because of the radiation concerns. But if you can image it with low doses, like we can with the Alcyon system, like we can use 1.5 or 1.8 millicuries of thallium for a stress image, we can get reasonable, 10 to 12 millisieverts radiation exposure in patients who, for whatever reason, we want to do exercise imaging or we don't want to do PET imaging, and we want to get the more sensitive radio tracer. So this is an interesting story. So this is an 18-year-old male who has some second-degree AV nodal block that conducts one-to-one with exercise, and as part of that workup, he underwent coronary CTA. And that CTA shows a right coronary artery arising from the left sinus of Valsalva and had non-exertional syncope approximately 1 year ago. He's very active in basketball and wants to evaluate his need for reimplantation surgery or correction of his anomalous coronary artery. So this is a complex scenario, one where we want to be both sensitive and get good high image quality. So I'm going to go here to the images and use attenuation correction. And the first thing I'm going to note for you is that even with the Alcyon, that the image quality on the with the attenuation correction, non-attenuation correction images, it's okay. I think it's not terrible. And the basal portions, you get a little bit of heterogeneity. But look at what we get with attenuation correction. We get these nice, beautiful thallium images, right? They look like PET images. This is a thin 18-year-old. So do I have a volunteer to describe whether somebody sees any perfusion defects on this thallium image? That's kind of not a fair question to ask, but I will I'll go through this with you. So thallium imaging is done with a stress redistribution or stress rest image, meaning that we take the patient, we exercise them in this case, we inject them at peak stress, we take an immediate image, and then for the resting image, we don't re-inject them like we would for the tech-labeled radio tracers because the half-life of thallium is so long. We just wait for approximately 4 hours and let the patient come back for a resting image. And so what you can see here is in this basal infroseptum, there's a small perfusion defect that is consistent potentially with RCA territory ischemia that fills back in with the delayed image. So somebody's asking me, why do we choose thallium in this case? Again, it was for higher sensitivity in somebody who's thin, and we want to ensure we get the we optimize the physiologic use of thallium and its ability to track flows more linearly at high flow rates compared to the tech-labeled tracers. In this particular case, you can see that this young gentleman was very thin. And knowing those things, we opted for the thallium imaging. Why not use quantitative PET with dobutamine? We could have used quantitative PET with dobutamine. However, we wanted to use exercise because, again, a young healthy person who wants to play basketball. Okay. Any other questions? Well, I'll do one more image. This is kind of a cool case. We haven't shown any amyloid cases. Do I think ammonia PET would be better? Yes. Yes, if we had ammonia. We did not have access to ammonia. Did he get unroofed? Yes, he did. So here is a technetium pyrophosphate image. If anybody wants to, in the Zoom chat or shout out, tell us what's abnormal in this image. TTR, sure. Okay. What else? The ribs, right? So here you see these focal areas of rib uptake. Okay. It's actually not the most strikingly positive pyrophosphate image. probably a grade 2 on the 0 to 3 scale, similar to sternum, I agree. But these areas suggest that there were rib fractures. And we see this. We routinely recommend review of the images in our fusion view. And you see these areas of rib fractures there on the fusion image right there. What is TTR? TTR amyloidosis. Okay, well, thanks everybody. Appreciate everybody's time, and again, thanks for Dr. Dabala for setting this up and asking us to participate. I hope everybody got a lot out of this. It was fun for me, and stay safe. Now put your masks back on and go back outside.
Thank you. Fantastic session, actually, and I learned a lot, and thanks to all the attendees, we had well over 250 folks even towards the end of the session. So very, very helpful. I know you're clinically very busy, so particular appreciation from ASNC for volunteering to do this session this afternoon.
Thanks, Sharmila.
All right, bye-bye. Stay safe, everyone.